Afternoon, everyone. Thank you for registering for our webinar all about RPM in rural communities and how it is bridging the gaps for access to care. We are so excited that you joined us today, and just so everyone knows, the session is being recorded. However, no one's cameras except myself and our guest will be shown, and none of your contact information will be shown as well, just so that people have access to the webinar that we're not able to attend after the fact. So we'll get right into it today. Like I said, we are discussing the role of RPM in rural communities. So to set the stage for today, we have an agenda going to be discussing a little bit about Impilo and what we do, the introduction to our wonderful speaker, and then we'll go into our conversation, a fireside chat style of RPM's role in rural health communities, and then give the audience some time to ask some questions, whether that be about rural health communities and RPM, Impilo, anything in between, we are happy to answer. Before we get started, my name is Haley Minter. I am the Marketing and Demand Generation Lead here at Impilo. I run our monthly webinars, so feel free to join month after month for great content from everything from RPM to best practices in rural communities like we're talking today. So a little bit about Impilo. We are enabling healthcare into the home through connected device operations. We have a platform that allows providers to manage operations, logistics, and data all in one place to support their virtual care programs. And we're able to integrate this actually into providers' current workflows through our comprehensive API. So really, Impilo is the ecosystem that is empowering virtual care and remote patient monitoring to work. We would love to chat more about this. So if you have any questions, feel free to answer them in the Q&A or ask them by emailing sales@impilo.com. An introduction to our wonderful speaker, we have Allison with us from a healthcare center in Hawaii. It is a rural health area, and she is so excited to chat a little bit about what she's doing. Allison went to school at Duke University School of Medicine, and she is a physician's assistant. Allison, is there anything else you would like to say about yourself?
I guess I have a background in working in community health, and then also working at a public university as well, seeing students.
Awesome, fantastic. All right, so we'll jump right into it today. Allison, so glad that you were able to join the call today to spread your knowledge and just learnings that you found from working in the practice. So can you share an overview about your practice and its role in providing healthcare to your community and what that looks like?
Yeah, sure. So Ko'olauloa Health Center. So we're based on Oahu. We're on the North Shore. A lot of people know our region for its wonderful surfing, and then also for just its beautiful scenery. It is considered a rural community on Oahu, and we serve about 23,000 people in the community, or we have 23,000 people in the community. We do have one of the highest percentage of Native Hawaiians in our community. So about 35% of the community is Native Hawaiian. And then if you were to include Native Hawaiian and other Pacific Islanders, that's about 50% of our community. So that does present some unique challenges that comes along with that community. We do also have some agricultural workers, usually from Southeast Asia, also some Pacific Islanders. And then in terms of social determinants of health, there are definite issues with poverty, access to fresh groceries, and we're about 45 minutes, 1 hour away from most specialists and major hospitals. And we have some barriers as it relates to just general education and some cultural barriers. And because of all of this, we are designated as a health profession shortage area for several different things. Primary care, dental, mental health. So not a lot of resources within our community. And so we are kind of one of the main hubs to help patients.
Awesome, Allison. Thank you for giving us that information. I know a piece that you mentioned is you're about 45 minutes from the closest specialty or specialty hospital. So how does your practice address access to healthcare while dealing with those geographical boundaries?
So first of all, within primary care, we try and do as much as we possibly can to try and help patients within the clinic. So trying to really optimize our medical care and try different things before we even consider trying to refer somebody out. We are actually pretty fortunate that we do bring in a couple of specialists into our clinic. So we have a part-time OBGYN. We also have a part-time podiatrist that'll come into our clinic. And then on site, we also have dental and also a pharmacy on site at one of our clinics. And so with all of those services, trying to help our patients the best that we can, we are actively trying to resume, because we lost during COVID, our behavioral health services. So also trying to bring that back into our patients as well. And once we do have to refer somebody out, transportation can be an issue for our community. So if their insurance does cover transportation, we have somebody who helps to coordinate that with their insurance. And then also if somebody needs transportation to our clinic, we actually have a clinic van, and then we can coordinate where one of our staff members will pick them up and bring them to our appointment.
Great, thank you for sharing that. So you touched a little bit about your patient population, the boundaries that you're dealing with, and just overall how the practice functions. I know through our initial conversations that you guys are doing some work with blood pressure cuffs. So I'd love for you to walk us through that device program in your practice, and what does that process look like between provider and patient?
Sure. So we actually started by giving out blood pressure cuffs. This was kind of early COVID time, and just before that, when we had some federal funding. And it was pretty simple at that time. It was just, does a patient have hypertension that's not controlled, or do they have elevated blood pressure? And we're trying to figure out if it's hypertension. And they would just give the patient a cuff to use. But we weren't getting too much data back. It was really dependent on the relationship between the provider and the patient, if the patient would bring back data. And so what we've been trying to do is to change that program to try and make it so that we're more likely to get data. And then we're also supporting the patient in ways beyond just checking their blood pressure. So talking about, foods that they're consuming, how they're preparing food, talking about, smoking, for example, and physical activity. So how our program is operating today, and we're really in our early stages of making these changes, is that first a patient is identified to see if, again, they're uncontrolled hypertensive, they have elevated blood pressure readings, or if there's just a concern that the provider will have. We empower either our medical assistants, or providers to go ahead and give a blood pressure cuff. Currently, we are able to give these for free, and we're allowing the patients to keep the cuffs. They're not having to return them. And then we have the medical assistants are the ones that are teaching the patients how to utilize the cuff, giving them some basic information about how to check blood pressure, making sure that, they're not eating within 30 minutes of taking their blood pressure, that they're, in the correct posture for taking the blood pressure, supporting their own, kind of all of those different pieces. And then giving them that initial blood pressure log. We have very few patients who are tech savvy. So with those patients, the medical assistant might also teach them how to connect the cuff to an app. Currently, we're using Bluetooth apps because that's what we have. And then I can speak later about what we're trying to do. And then they will set up a follow-up with the medical provider to be seen in person. About halfway to that appointment, our registered nurse will give them a phone call, talk through those different factors, smoking, physical activity, nutrition, things like that. And then also get data from them. What have your blood pressure readings been like, or have you been checking it? Do you have any questions? And then our registered nurse is putting that into the electronic health record. Our EHR actually has like a standardized protocol to use for this type of program. And so at least that with each patient, she's kind of going through the same types of questions and can indicate if the patient is improving, if they're declining, or if they're kind of staying stagnant. So that's kind of how our blood pressure program is working currently.
Great, thank you for sharing that. I know you touched a little bit about patient engagement and activation and that being a problem for you. Obviously, for many virtual care and remote patient monitoring programs, specifically in rural communities, that is a prominent problem that many people are seeing. So how would you say, how receptive are your patients to this program? And are there any educational factors that play a piece in getting them more engaged or activated within the program?
I would say for the most part, patients are pretty happy to receive anything that's free. We're not charging them currently any extra amount for this. So pretty receptive. I've only had, like, say, one person personally who declined the program. And we're just going to continue to offer it them and educate them. So the main things that we've been doing to try and get people to understand the importance of controlling blood pressure and the benefits of this program is showing them the numbers and explaining to them kind of where do we want their blood pressure to be, where are they at on that range. And it really helps when you have something like the American Heart Association uses colors, makes it very easy for patients to see, I'm in a dark red zone or I'm in an orange zone. Can really break down those numbers into a way that makes more sense to them. And then also explaining that this is the silent killer. You may feel okay, but here are things that we're concerned about if the blood pressure does not improve. And usually it helps to kind of find a why. And so I just had a patient the other day said that their why was, I want to improve my blood pressure so that I can be around for my 7 grandkids, and there's an 8th one on the way. So helping them to find another reason just beyond ourselves in the healthcare setting, saying, hey, this is a concern to us, but we want them to also be active participants in this and find a reason why they should even care about this. And that's been very helpful for us to get them to consider participating.
For sure. At Impilo, we're big advocates for education, just to keep patients engaged and for them to be their own advocates in their healthcare journey. I'm sure other providers on this call feel the same way. It's sometimes hard to get patients engaged, but when you have the benefit of sometimes offering free product as well as educational resources, you're really able to tie them in. So I think that's a key piece that providers, specifically in rural health, can kind of toggle off of to improve their programs or at least try to optimize their current practices. But with your program, obviously it's quite different from traditional healthcare delivery, especially in Hawaii with those barriers. So how would you say that this program that you have been implementing is playing a role in your approach to healthcare delivery?
So we're trying to meet the patients where they're at. So by giving them an advice so that they can check their blood pressure at home, we know that their blood pressure is going to be, probably more reflective of their baseline when they're at home. As soon as they come into the clinic, their blood pressure tends to go up for various different reasons. There's a lot of, nerves, or people might have true white coat hypertension. And by allowing them to take their blood pressure at home, they could be more comfortable. We're also trying to do our program so that the follow-ups are via phone call primarily, only in person with the provider, again, to try and reduce barriers to access by not trying to make them come in every single time to check in with our registered nurse. There are other clinics that I have talked to on island who are maybe not as rural, and they do that. But for their population, it works every single time that they're having a blood pressure check, the patient is coming in. But for our patients, we just probably will never see them again. And so by meeting them where they're at, by thinking about what challenges our community has, we're trying to make the program fit for our population. And we also know that there is the opportunity to bill for these services once you meet a time marker within a month. I believe it's over 20 minutes. We know right now for our patients, that will be a barrier. As soon as we talk about any amount of potential charge or bill, they will back out and not do it. So in these early stages, we're not even billing because we just see this as such an amazing opportunity for our patients and for our community at large to make a change that we're not even tossing in this idea of billing or the potential for the patient to have a fee at this time, so that we're making it more likely that they're going to trust us and participate in the program. That's the bigger thing that we want right now, since our blood pressure control numbers have not been great.
For sure. And I want to loop around to what you said in the beginning of meeting the patient where they're at. That's so important. I'm sure you and I both agree, but really just working with the patient is of utmost priority, because at the end of the day, they're the decision maker for their healthcare journey. So there's many tools, and Impilo has a plethora of resources on our blog that people can check out if they want to learn more. But really the emphasis is meeting the patient where they're at and their personal journey. So that being said, obviously we want the outcome to impact the patient. So can you speak to any sort of impact, good or bad, that you've seen that this program has had on any of your patient population?
Sure. So first I'll say kind of a unexpected impact. which is by giving a blood pressure cuff to an individual, we're really not just giving it to that one person, we're really kind of giving it to their family. So in Hawaii, it's very, very common to have multi-generational homes where people are living with grandma, grandpa, aunties, uncles, maybe even cousins. So if we're giving a blood pressure cuff to one person in that home, other people in the home have access to it. And so we hear many stories about that. They'll be like, hey, you got a blood pressure cuff? And they'll be like, no, I don't, but so-and-so in the house does. And so it's been really nice that by getting blood pressure cuffs out there, we're allowing other patients in the home who are very likely our patients to also have access to a blood pressure cuff. That was not something we expected, but it's something that we hear about pretty frequently. And then in terms of just kind of specific impacts for those patients who were more motivated and actually did keep a blood pressure log, we've had like improvement in our blood pressure control. Definitely still room for more improvement. But we had one patient in particular, I was asking the staff recently, hey, do you have like kind of a patient case that really stands out to you with giving them a home blood pressure monitor? So this patient was a little bit tech savvy, so they actually did use the Bluetooth connection to an app, and then they would actually take those blood pressure readings and email it to their doctor. And over time, they were actually able to go from 2 to 1 blood pressure medication and be controlled on that medication, which is huge. So to be able to get their blood pressure under control and also eliminate a medication is amazing. And that's what we're hoping for, is more stories like that, where patients are active participants and are actually seeing the numbers change, and even reducing or eliminating medications would be our ultimate goal.
That's amazing. I can't even imagine, as your business and this program continues to scale, how many of those success stories will come out of it. But obviously, we both know in order to get your business to scale, you need to start small, and there can be troubles with implementing the program and different barriers. I know you touched on just patient engagement and participation and a little bit about data collection, but are there any other barriers that really serve as a roadblock to implementing this program for your patients?
The main thing for us has been also trying to figure out how to integrate this into our electronic health record. So we actually recently changed our EHR in the fall of last year, and that actually has improved our options around this program, because there is a standardized plan that's built into our EHR for monitoring patients with uncontrolled blood pressure, or if it's true hypertension. And so that's been very helpful for us, because before we didn't really have a good way of how to standardize like our data collection for those things that were not just numbers, for example. So for those things, like I had mentioned, like smoking, or how is their physical activity. So that was actually one of our biggest barriers. And then also staffing. And that is something we could still ramp up and get some additional staffing hours. But we actually do have a nurse or an RN who is now on our staff, so she could help with this program. When this program first started, kind of in COVID time, they didn't have a nurse to be able to touch base with those patients. So those have been 2 barriers that we've seen improvement in. And then kind of our next step, of course, is data. So I don't know if you want me to speak to what we're hoping to do in the future.
Yeah, for sure.
So right now we have Bluetooth cuffs, but with Impilo, we've been talking about trying to switch to cellular cuffs. I would say our biggest thing about this program, patients are very willing to accept the cuff. They're very willing to consider the idea of checking their blood pressure, but they're not really good at follow through with actually giving us back blood pressure data. And so I would say that actually less than 1/5 of our patients given cuffs are giving us good data back. And if they are giving us data, what they're generally doing is writing it down on a piece of paper, because we'll give them a log. And then just because of time and staffing hours, that log will be scanned into the chart. And it's not super beneficial for us because we're not getting discrete data. We're not having those individual blood pressure readings as data points in our EHR. So the benefit of considering cellular cuffs for us would be first, that the patients don't have to, they are not required to connect to an app in order for that data to get to us. The data would go straight from the patient checking their blood pressure and straight into their electronic health record in a discrete field. And that would be really helpful for us to track the data and actually see that the patient is using the blood pressure cuff, and we could see in real time when are they using the blood pressure cuff. And then also that'll just reduce energy from the patient and them having to keep track of the blood pressure numbers. And then also from our staffing, whether it was scanning in the data like they have been doing, or if we were to transition to manually inputting the data, which is what we're starting to do. Again, if we could reduce that and have the staff not have to focus so much on data inputting of blood pressure readings, but instead focus on, hey, yep, let's see what your average has been, and then let's just spend more time actually talking about how we can improve your blood pressure, how we can better support you. That would be extremely helpful. So that's where we're looking to go, as we're trying to go towards cellular cuffs so that we can reduce all of these barriers, both for our patients and for our staff.
I'm so glad you spoke to that. Through every conversation I've ever had with rural health providers, the common denominator is, at the end of the day, the data is really hard to collect. And the beauty about platforms like Impilo is the data all lives within one place, and through the help of cellular devices, we're able to obtain that data without any manual labor or action to be taken. So really negates that area that patients didn't want to participate in, now optimizes it by automating it for the patient and kind of removes that barrier completely. So we are so happy to be working with you and excited that you shared that, because I'm sure other rural communities and providers are kind of on that trajectory of wanting to grow and wanting to scale into cellular devices, but obviously you have to start somewhere. But moving off a little bit about your program specifically and more into general remote patient monitoring, obviously you're a physician's assistant and an expert in the field. So would love to hear your perspective on how you think RPM is going to scale specifically in rural communities as we progress into the future.
I think we're going to see more of it. And I've heard about it in non-rural communities already. So definitely going to see more around, something like a blood pressure cuff, but the glucometers are already out there. And I think Impilo already has, access to that as well. But being able to have patients give you data without those barriers to access, like having to come into the office, or even for us, telehealth can be a barrier because patients might not have the right understanding or the right devices to do an audio visual type telehealth. So being able to scale up will be amazing. We're going to see more of that, I think, in rural health and beyond, because we're getting real-time data. We're reducing barriers to access for everybody involved, and we're actually getting probably better data when it comes to blood pressure by having a person check this at home in a more relaxed environment than in a clinic. So yeah, I think there's no question that we're going to see more of this, especially as EHRs get more powerful and integrations, get better, and especially as, we get AI involved and whatnot. Like, who knows what's going to happen in the future with managing patient panels using remote patient monitoring.
For sure. Obviously, as the industry continues to grow and more rural communities are informed about what remote patient monitoring is, I'm sure providers, small practices alike would like to adopt programs just like yours. So are there any tips or pieces of advice that you can give the attendees today about implementing a device program in a rural health area?
So first, it would be understanding your community. So finding those staff members in your clinic, usually it's clinical staff members or people who are from your community, especially in rural health. Your staff members tend to be from the community, so they know who these patients are. They're usually their family members, their friends, their school classmates. Gathering that information to understand what are those barriers for your patients. For us, transportation is a big one, for example. Cost is a big one. So understanding what are those barriers for your patients, and then looking at your staff and seeing what can we do with our staff members, or do we need to change staffing? to try and help our patients overcome those barriers. But I really think the key is identification of what your community needs. And then also if you are, say, near another clinic that is already doing a program, talk to them. And that's kind of something that I had done. It's a clinic. They're about an hour or so away from us. They're not exactly like us, but they are another federally qualified health center, and they already had a program up and running. Speaking with somebody and seeing, hey, what's been working for you? They had some protocols in place, seeing if they'll share information with you, and then tweak it. That way, you're not creating it completely from scratch. And so that was really beneficial for us, was talking to a similar clinic, getting an idea of what they're doing for their community, but tweaking it to better fit for our community, and then using their protocols as like a jumping point, or their handouts as like a starting point for us to kind of create our program. But I think the key in rural health is really, really, really understanding your community so you can get their buy-in.
Awesome. Thank you for sharing that. Obviously, when you're starting a program, you need to start somewhere, and that includes funding. So can you give any tips or avenues that federally qualified health centers can pursue in order to get funding to implement a program?
Yep. So we started with federal funding, and that was kind of the beginning of it, because there was an emphasis, or there still is an emphasis, on trying to improve blood pressure control. And that was like the beginnings of it. But also the American Heart Association locally has been very active in communicating with clinics in the state. And they have been very supportive for us for also finding additional funding for things like getting us larger cuffs to fit our larger patient population. And then also grant funding. So currently looking into applying for grant funding. This would be specific to my profession, to PAs, but I'm sure there's generalized grant funding, and then also, grant funding to us specific to other professions, for example, physicians or nurses, to try and improve health equity within a community. So something like a program like this would be beneficial with that. As I had mentioned earlier, there is the option to bill. It's not something we've explored. As I explained, that'll be a reason that our patients just will not want to participate for now, but it is something that we're planning to do in the future. So most EHRs now have a way for you to track for chronic care management, how many minutes within a month you have been working with this patient on chronic care management. I believe it's if you make over 20 minutes within a month is when you can start billing. So that'll be the next step for us. But of course, if you can bill for the services that you're providing, then do that. Every little bit counts. The other clinic that I had spoken with, they do that. And the patient is aware that there might be billing, but what they do is that if the patient is billed for those services and the patient does not pay, they just write it off. And so essentially the patient is not paying for the service. And so that's pretty common within federally qualified health centers, is for practices to kind of absorb smaller costs that patients were not able to pay, but at the same time still getting some reimbursement from the insurance company.
Great. Thank you for sharing all that, Allison. I'm sure it was very helpful, especially to our attendees that are in FQHCs. But before we wrap up our fireside chat and jump into the Q&As, are there any final thoughts that you'd like to share with the group?
We're really excited to try and move in the direction of cellular cuffs. We've already started testing out a cuff with Impilo and seeing how the data goes directly into the vital section of a patient's chart. And just have to do some final tweaking with that connection, but so excited to try and move in that direction, and make a positive impact on our community, and really looking forward to just kind of all that's going to come with remote patient monitoring in the future.
Great. We are so excited to see how your program continues to scale, and obviously having Impilo be a part of it. But thank you, Allison, for such an informative session. We're actually going to jump into our Q&A, and today we actually have some in the queue. So for our attendees, feel free to type any question that you have for myself about Impilo or about Allison and her practice and her program in the chat. But we'll get started with some of these Q&As. Allison, these are all geared towards you. So we'll start following our last piece of the fireside chat about funding. So how did you start your funding process? What does that look like?
Oh man, so I wasn't there at the very beginning, but we have a very active chief operating officer, and she was the one that was key in connecting with federal funding. I believe it was through HRSA, but that was a key piece there. And then, like I said, the American Heart Association was also a valuable resource for us. I just had to tell them what our need was, like, hey, we need more extra large cuffs, or we need more machines, or whatever it is. And that's it. Our connection went out, and she was the one that found the funding and came back and said, great, I found funding for you. I'm going to send you some cuffs. I'm going to send you some, machines, and then any other resources there. So I would see if, especially within the FQHC world, if you have a connection to your local American Heart Association representative. That was very important for us.
Great. Thanks for sharing that, Allison. Another question that we have coming in are there any mistakes or things to avoid when starting an RPM program in a smaller community?
I think a mistake may be not starting, because I think that anything that we've tried, even if maybe it wasn't the best choice, it gave us data to learn how to change. So I guess this is a mistake that we made. We bought more cuffs, like machines with cuffs to give out. And we didn't check to see that that machine could attach to an extra large cuff. And so I guess, yeah, that was a mistake for us, but I take it as a lesson learned, which is in the future, we're always going to make sure that the machines that we're considering can attach to extra large cuffs. That's important. Our community, Native Hawaiian Pacific Islander community, does tend to be a little bit larger. Regular cuffs generally don't fit on those patients. It's going to give you very inaccurate data. So I think that just start. And then if you do make any kind of slip ups, then I would use that as data to pivot.
Awesome.
Yeah, but I think not starting is probably the biggest mistake. We figured it out as we went, and we adjusted as we went. Within a smaller community, of course, you always have to be careful, because word spreads fast. Here they call it like coconut wireless, where if something happens with like one person, next thing you know, the entire community knows pretty quick. So good intentions, I think, matter. And acknowledging to the patient that we're trying to help you, we're trying this program, and let us know if there's any ways that we can improve. So being open to feedback, being open to changing how your program is, rather than just seeing it as a static program.
Fantastic. And one final question to wrap up the call today. I feel like this is a good place to land. Do you have any final tips for just RPM programs in general, or device programs in rural communities? Anything top of mind?
Yeah, because I know so similar to before. I think if you're really starting from scratch and you're not quite sure what to do, let's say it's blood pressure specific, since that's much of what I was speaking to. There is the American Medical Association, AMA. They actually have coursework that you can go through that'll talk you through starting up SMBP, so self-measured blood pressure program. So that would be one kind of way to consider things, as like looking for coursework that can teach you about this program. Also, I think the American Heart Association has resources as well. So seeing what's out there in terms of resources. But I think a really valuable one, again, is if you have access to any other clinics somewhat near you, maybe if they're not near you, but if you just have access to a clinic who's already doing a program similar to what you're interested in, talking to them, talking to the person who's in charge of the program, seeing if they'd be willing to share their information with you and their knowledge, especially if they're somewhat close to your community, then their program might be, similarly suited to what you might need within your community.
Awesome. Well, thank you, Allison, for all of your thoughts and advice throughout this session. I'm sure it was so informative to our attendees, and I surely learned a lot. I'm so excited to continue working with your practice and see how your program continues to scale over time. But as always, thank you to all the attendees for joining this month's session. We will be hosting another one next month, so stay tuned on the topic and date. But as always, our sessions are recorded, so you will receive an email with the recording as well as the transcript, and feel free to share with any colleagues or individuals within your network that would find it valuable. Again, my name is Haley Minter. Feel free to connect with me on LinkedIn or shoot me an email to talk all things Impilo. We hope you have a wonderful rest of your day, and thank you all for joining.